Okay, this is my newborn assessment video. First, you're going to want to identify the baby with the mother, and you do this by checking the corresponding bracelet with both of them. And next, you're going to want to prevent heat loss. First thing you're going to do is pat dry the baby to prevent heat loss from evaporation. Next, you're going to place a towel or a paper towel under the baby in order to prevent heat loss from conduction. Next, you're going to prevent heat loss through convection, which is basically keeping them away from windows, keeping them away from drafts, and keeping them away from basically anything that circulates a lot of air. Lastly, you're going to prevent heat loss through radiation by keeping the baby away from cold surfaces, away from like a wall, away from anything, again, resembling a draft. Next, you're going to check the baby's APGAR score. The first thing that you're going to assess is the baby's heart rate. And the heart rate is checked with the bell of your stethoscope. And you're going to place the bell of your stethoscope on the center of the chest and monitor the baby's heart rate. And the average heart rate is from 110 beats to 160 beats. And also, I need to mention that the APGAR score is taken in the first minute of life, and then again at the 5th minute of life. So, also, every category has a scale. Every category has a score of 0 to 2. And the minimum score you want to have for a baby would be 6. Now, a score of 1 to 3 means that you need to perform a neonatal resuscitation on the baby. A score of 4 to 7 means that you need to stimulate the baby by flicking the foot like so, or rubbing the baby's back in order to coax them into breathing better. And if their APGAR score is between 8 and 10, you're just going to have, hands off and observe the baby closely. So, after you take the baby's heart rate, you're going to check the other vital signs, but when also vital signs can vary depending on if the baby is active or inactive. If the baby is active, the baby's vital signs will be higher. If the baby is kind of just laying there and inactive, then their vital signs will be lower. Now, next thing you're going to check is the baby's respirations. You're going to check the rising and falling of the chest, and the average respiration rate in a baby is between 30 and 60 breaths per minute. You also check for respiratory distress, and signs of that are chest retractions, sounds like grunting, and nasal flares. Also, the baby will have surfactant in their lungs, and this is what allows the alveoli in their lungs to be able to have enough surface area to expand while they breathe. So less surfactant means more respiratory distress. Next thing you're going to check is the baby's temperature. It's normally checked axillary. So you're going to place the thermometer under their armpit like so, and just kind of clamp their arm down over it. The average temperature in a baby will be between 96.8 and 97.7, and that's for axillary. Their blood pressure. An average systolic blood pressure on a baby is between 65 and 95, and an average diastolic blood pressure in a baby is 30 to 60. You're going to check the baby's posture. Ideally, you would want the baby to be flexed instead of limp. When the baby's flexed, it means that, they're healthy and they're active. And if the baby's limp, that is a sign of trouble, and you should really observe them over that. The last thing you're going to check in the APGAR score is the color of the baby. This is what babies get counted off for the most because of something called acrocyanosis, which is where the baby's hands and feet are blue and the central part of their body is pink. So, abnormalities in a baby. When you flip them over, you're going to check their spine. And at the base of their spine, you're going to check for a little tuft of hair or a little dimple, and that signifies that they have spina bifida. You're also going to check for a simian crease in their hands, and the simian crease indicates that they have Down syndrome. Also, you're going to check for polysyndactyly, which is where a baby has an extra finger, and syndactyly, which indicates that they have webbed fingers. Okay, now we're going to move to the head. There are suture lines in the baby's head, and this is what allows for molding when the baby goes through the birth canal. This allows the baby to easily pass through the birth canal without it being very difficult for the mother to push the baby out. So there are types of edema that happen with the baby's scalp, and there's something called caput suicidum, which is where the baby has edema and it crosses suture lines. And then there's another thing called cephalohematoma, which is where the baby will have edema and it will be on one side of their head and it does not cross suture lines. And the next thing you're going to check in the baby's head are their fontanelles. The anterior fontanelle, shaped like a diamond, and that closes at about 12 to 18 months. And then the posterior fontanelle is triangle shaped, and it closes about at the end of the baby being about 2 months old. Now, flipping the baby over to the back again, the Mongolian spots are spots over the lumbar region of the baby, and it's normally found on ethnic babies, and it's nothing to be concerned about because it's actually fairly normal. It'll go away after a few months to years. And also, you want to make sure that you're not assuming that the baby is getting abused because it looks similar to bruises. Okay, turning back to the baby's face, there's another skin condition called port wine, and it's basically shows up anywhere on their face. It's a very large red birthmark, and it is also no reason for concern, but the only way to actually get rid of it is to have surgery done on it, like laser surgery, anything like that. The next thing you want to look for is stork bites, and those are found along the baby's neck. They're also called salmon patches, and they'll be found on the baby's neck, and those are also no reason for concern. They'll go away very soon. And there is another thing concerning the baby's back. When you turn them over to their side, they will have one side of their body be a red color, and then the other side will have some pallor, and that's called a harlequin sign. And an intervention for that would be to flip the baby over to the other side so that you can relieve the pressure off of the red side. Now, on their face again, there are little white dots across the baby's eyes and on their nose, and that's called milia. And you should not puncture these. You should educate the mother to not puncture them because they can lead to infection, and they will go away within a few months to years. You're going to measure the baby's head from the brow, and then you're going to measure their chest and also their abdomen. When you measure their head and their chest, there should not be much of a difference between them. They should be nearly the same size, but then the abdomen is going to have a smaller circumference compared to the two. Now the eyes should be a slate blue color, and this is also the moment where you want to apply erythromycin eye ointment to the baby's eyes. and you apply it from the inner canthus to the outer canthus. Next, you're going to observe their nares. Put your gloved finger over their nares to make sure that they're breathing well when you cover both of them. The next thing you want to look at in the mouth is if they have something called a cleft palate, and you're going to use a gloved finger to swab the upper part of their mouth, and that will basically indicate if they have cleft palate or not. You're also at this time going to check the sucking reflex, and then lastly you're going to check their gag reflex as well. And at this time too, you can run your finger across their cheek in order to see if they have a rooting reflex, which is where they turn toward wherever their cheek was brushed at. The Mora reflex. This is a reflex where if you make a loud noise, like clapping your hands or jarring the crib to the baby, they will have the reflex of kind of pushing their arms and legs towards the midline of their body in like an embrace sort of motion. And the next type of reflex you're going to want to look at is the tonic neck reflex, which is where if you turn the baby's head to the side, this side of their body will extend or abduct from the body, and then this side will flex. The next reflex you're going to look at is the palmar reflex. If you place something in the baby's palm, they will grasp it tightly. Now, to the ears. When you fold the pinna down, if you let go of it and it stays, that means that you're dealing with a preterm baby. And if you pull it down and it springs right back up, that means that you're dealing with a term baby, and that's normal. The scarf reflex, or the scarf sign, is where you fold the baby's arm over their midline, and if you meet resistance, that means that you're dealing with a term baby. And if you do not meet resistance and the arm goes all the way over past the midline, that means that you're dealing with a preterm baby. The next thing that you want to look at is the square window, and this is where you kind of take their wrist and bend it sort of, and it kind of makes like a square type of shape. And if you're able to completely bend it, like so that their fingers are kind of touching their forearm, then that means you're dealing with a preterm baby. But if you're meeting resistance, that means that you have a term baby. The arm recoil reflex is where you take their arms down, and then when you let go of them, they bounce back, just like so. And looking at the chest, there will be excretions coming from it occasionally, and that's called witch's milk. And that's normal. It just means that they're basically separating from their mother's hormones, so that kind of comes out in response to that, and is completely normal. And also the nipples should be a diameter of 5 to 10 millimeters. Now, the bowel sounds, you're going to listen to them around the umbilicus with your stethoscope in all 4 quadrants. And also, something you'll check on the umbilicus are the umbilical cord. Now, the cord has 2 arteries and 1 vein. Now, the first shunt is called the ductus venosus, and that takes the ductus venosus, and then the next one will be the foraminal valve, and then the last one will be the ductus arterius. Also, when the baby's umbilical cord has been cut, you're going to want to keep it as dry as possible. So you can do this by folding the diaper away from the umbilicus in order to keep it dry, and you can also wipe it off with alcohol. And that umbilical cord stump should fall off in about 8 to 10 days. So, also there's something called Wharton's jelly, and that is something like a cushion for the umbilical cord, and it keeps like all of the vessels intact for the umbilical cord, and it can also show if a mother has been using drugs, like, and they can also, like, tell you when she started to use drugs, like, prenatally. So, the ductus venosus takes blood from the inferior vena cava to the right atrium of the baby's heart, and from there, the blood goes through into the foramen ovale, and then that takes the blood to the left atrium of the baby's heart. And lastly, the ductus arteriosus takes blood from the pulmonary artery to the aorta and out to the placenta. The ductus venosus, that shunt closes functionally, like, as soon as the baby's umbilical cord has been cut, and permanently it closes after about a week. For the foramen ovale, that one functionally closes at about 2 hours, and it permanently closes in about 3 months. And now the ductus arteriosus closes functionally after about 15 hours of birth, and then it permanently closes in about 3 weeks after birth. And moving down to the baby's legs, you're going to look at the underside of their legs and see if their creases are symmetrical. If they are not symmetrical and there is, like, an extra crease in the baby's leg, then you will know that they have some sort of hip dysplasia, which is where their femur is dislocating itself from that socket, and they will basically have to wear, like, triple diapers, and they will have to kind of have a brace and keep their legs abducted for a while after they are healed from it. You also can check hip dysplasia by rotating the legs around in a circular motion. If you start to hear clicks, that means that they could have a hip dysplasia problem. The popliteal angle is where you take the baby's leg and you bend their knee down, and there should be some resistance, but it should go back to being flexed. The Babinski reflex is where you take your finger and you run your finger across from the ball of their foot to the heel of their foot, and they should have a reaction of their big toe, like, extending dorsally, and then the rest of their toes spreading outward. The heel to ear reflex is where you take the baby's foot and put it near to their ear. If there is resistance, then you're dealing with a term baby, and if there is no resistance, then you're dealing with a preterm baby. The last thing that you're going to look at is the baby's genitals. A male baby will have rugae on their scrotum, and that means that they are term. And if the baby does not have rugae on their scrotum, that means that they are preterm. For female babies, preterm female babies will have a prominent clitoris and their labia minora will stick out. And then a term female baby will have the labia majora, like, covering the labia minora. And that's about all for the assessment.